professor at the School of Nursing at MSU Mankato, and it was a makeup day. We had some faculty go out, some have surgery, so I was doing IV test outs in our skills lab. Because I kind of cover all the things here at MSU and clinical, simulation, skills lab, and then I teach med-surg courses. So I made it. And thank you guys for taking time out of your evening tonight to listen to me talk kind of about the last several years worth of research in an area that I became really passionate about in my master's program. I'm very happy to report, some of you have been following me since I started in my PhD program. I finished up my coursework. I just got my IRB submitted for my pilot study that has all come out of this research. So in my master's program, I became really passionate about looking at the gaps or disparities seen for children in foster care. And my initial kind of proposal was looking at medical home models. And it was in a nursing conference that I was encouraged to take a look at care coordination, since medical home models are much more physician-led, focusing on what can nurses do. And that kind of led into the abyss of what is this presentation, because care coordination in a lot of disciplines and a lot of areas doesn't exist, particularly in foster care. So I really had to pare back everything that I thought I knew and thought that I wanted to do and really take a look at what is the problem, or what do we even know about it? What works and what doesn't work for kiddos in foster care. So I'm presenting the results of two different sort of projects or papers that hopefully by the end of this semester will cross the manuscript finish line. I'm hoping. Is first a scoping review and a concept analysis. And just to get a gauge, is anybody here familiar with one or both of these research methods are? I'm seeing one head shake no, one with a couple yeses. Okay, so just in case, I did put in some explanations of what these are, since these are very much PhD driven type research, and they're gaining more traction in research again. They kind of haven't been given the respect that they're due, especially when you're looking at concepts and research topics where not much is known. But first thing I want to talk about is the objectives for tonight. And please bear with me, I have a lot of notes because it's a lot of information. I want us to understand first what the prevalence of foster care and the disparities this population experiences, to then understand what is known in the literature about care coordination and foster care. And this is the scoping review piece. And then the concept analysis piece is number 3, to conceptually define care coordination in foster care. So through a very research-driven process, I have defined what foster care what care coordination in foster care should look like, and the components that it should entail. And then lastly, look at recommendations for nursing practice to address health disparities for the kiddos in foster care. So I want to highlight that overall tonight, I have not conducted a study yet. It's coming, as well as several other studies. This is going to be a lifetime's worth of work in developing a research team, which right now it's a team of 1. So if anybody is passionate about looking at disparities for kiddos in foster care, I'll be done with my PhD next summer and looking to launch the next steps. So that's my little plug on that. But after identifying a gap in the literature, we need to define what it means, because it hasn't been defined yet. And then, as I mentioned, I just set up my pilot study to explore my phenomenon of interest. So let's look at the demographics first. Although some of these, it's allergy season. Although some of these statistics are a little dated, I have not been able to find the most recently published, and one of that reasons is so many kiddos got lost in the stacks, even more so than usual during COVID. and they just have not been able to recover from that yet. So these statistics are the most recent um, that I've got. So on average, in a year, anywhere from 407 to 440,000 children are in foster care at one point in time in the United States. And on average, 12,400 children that reside in Minnesota will have been involved in the foster care system at least once. Um, and since children are in such a transient nature with foster care, on any given day, about 7,700 children are involved in the system. The reasons for removal are usually threefold. They fall into three different categories, and I'll talk about how these categories kind of influence the ACEs, or adverse childhood experiences, um, that necessitate the need for foster care. But most first and prevalent is caretaker drug abuse. Please note that it says caretaker, not parent, because it's not always biological mom and dad that kiddos are living with. Also allegations of neglect, and these allegations of neglect are not, Kathy, I'm gonna pick on you. Say I send in a report and I accuse Kathy of neglecting her children. It is not the initial investigation. It is the children have actually been removed for serious concerns of neglect, not just the reportings. And then something we're seeing on the rise is 9% of child mental health needs. So what we're seeing, especially in Minnesota, and especially since COVID, is these are the parents that have not been able to care for their child's needs, and they quote unquote give up. They don't know where else to go. They don't have access, they don't have resources, and they don't think that they're the best caretaker for their child, so they will enter care. So I want to talk about the prevalence, excuse me, for mental health concerns, since that is going to be one of the nuanced topics of my dissertation, is leading back to the mental health care that is not happening for children in foster care. So I also want to just put in a brief disclaimer that all these statistics and this data that I have is very underrepresented, especially due to that transient nature of these kiddos and being able to track them, or having lack of access to appointments. So please know that the numbers that I do provide are probably much more inflated in reality if we had a true picture of what that looks like. But the National Conference of State Legislatures does quite a bit of the tracking for kiddos in foster care, and they found that 80% of children that enter foster care have or meet the qualifications for a mental health diagnosis, and that 23% qualify for more than one mental health diagnosis. And this is compared to only 18 to 22% of their non-foster care counterparts in the same um, child and adolescent population. Of the children in care, PTSD is found to be the most prevalent in 21.5%. And over 15% of foster care teens have experienced at least one major depressive episode in their lifetime. Other behavioral disorders, particularly the ones with the child mental health needs that I talk about, are ADHD, anxiety, mood disorders, fetal alcohol spectrum disorder, and a previously known ODD, or oppositional defiant disorder. That's no longer a DSM, or diagnostic statistical manually accepted term. It is now behavioral conduct disorders. So if you see something about behavioral conduct disorder, that used to be what we call ODD. And that does account for a large amount of these children with the mental health. However, so of all of these disparities, only 25 to 50% of children in foster care with mental health needs actually receive mental health related services. There's other non-biological needs, reasons that kiddos in foster care don't receive these services, and I'll talk about those here in a minute. But one of the reasons that we see all these disparities is these kiddos come from hard places. They have complex traumas. They're often asked to change homes, have frequent transitions, particularly if the mental health compounding factors or their traumas build, which I'll talk about. They come from broken homes. They don't get removed from their homes because it's functioning well. They also have inconsistent access to mental health services, and geography does play a big part in that. And with the primary providers overseeing their care, if that is happening, the solution has been to throw meds at them and to medicate these children. Children are going to often be placed into homes that have multiple children in them already, which makes it very, very difficult for foster parents to schedule, manage, and adhere to appointments, and makes it even more difficult to manage any medications that might be prescribed, especially in a multi-child home. They also have a higher outpatient behavioral health visit incidents. So the ones that are getting to appointments are seen at a 14 times higher rate than any of their general population counterparts. So what this is saying is we have an identified need, and they're needing to be seen more frequently. But part of that problem is these appointments are being used to manage psychotropic medications rather than to actually treat root causes or problems. Um, so all of these compounding factors, whether it's from the systems level, the family level, or the organization level, they lead to gaps in continuity of care. We're losing medical records and personal records, access to care, especially in our mental health deserts, in our rural communities. Excuse me. And I'll talk about the increased costs, is who is going to pay for it, as foster children are covered under Medicaid, which I'll talk about here in just a minute. So when all these factors compound, I mean, what is really happening to the kiddo is that if you can't manage behaviors, you can't manage traumas, um, they're at risk for multiple relocations into different homes. They may be placed into residential treatment facilities or group homes. And for the children that are not able to return home safely, so when a termination of parental rights is indicated, they lose the opportunity to have a success in a permanency placement or adoption placement. It's also important to note that these problems do not just end when a foster child turns 18. They still exist. They may not exist in the system, but they have major implications for successes in the future. They have harder times finding jobs, going to college. They have higher incidences of homelessness and incarcerations, substance dependence, and even for women, early childbearing. So the social determinants of health keep following this population, and compounding even into their future, whether it be with themselves or with their children. So I wasn't sure how familiar my audience tonight would be with the ACEs or adverse childhood experiences. So I wanted to just highlight what some of these ACEs could include and the effect that they're having on just overall children in Minnesota. So as I talked about, the three reasons for going into care are kind of categorized into the three ACEs. So it's abuse, neglect, and household dysfunction. Um, Abuse could be physical, emotional, or sexual. Neglect can also be physical and emotional. And then household dysfunction, it could be behaviors related to the child with mental illness. It could be mental illness on the caretaker. It could be substance abuse, and even difficulties in divorce, in battling out custodies. So um, they're commonly broken into, I think, 11, 10. I think there's one missing from this chart that was just recently added. But the prevalence of ACEs, what I wanted to highlight is that mental health issues in the home is almost twice that of any of the other experienced ACEs. Um, Now, it doesn't distinguish between the mental health issues on the part of a child or the caretaker. Um, But what we're seeing is the number of ACEs, because you can have more than one. I mean, you could have sexual abuse with physical neglect and a mental illness on the parent, or et cetera. The list could go on and on. But what we're seeing here on that graph on the right, excuse me, is sorry, I lost my train of thought here. Oh, yes. So that graph on the right is the the numbers kind of don't match up. When we're talking about prevalence of ACEs and we're talking about prevalence of disparities in foster care, the prevalence of the concurrent ACEs or having more than one is not easily or equally represented. So it's saying half of the children in Minnesota in 2023 experience no adverse effects. But the problem is that we only get about a 50% response rate on any given survey. So it's hard to determine what correlations do exist because the data is so skewed and segmented. Um, and then the other reason is the kiddos in foster care are not necessarily adequately represented in this analysis either because they're getting lost in the system. As I talked about, they're a very transient population, and it's very difficult to keep track of them or to even survey them, which I'll talk about um, in as part of a difficulty in conducting my research in my concept analysis section. So this is another really good picture to kind of identify where money is being put for children in foster care and the margins that they represent. So they are covered by Medicaid once enrolled. So as long as they're in the system, they're covered by Medicaid. Now, what's hard is if they are involved in foster care and they reunite with family, then they would be taken out of Medicaid. But if they're brought back into care, they'd come back onto Medicaid. So foster care only or children represent 3% of those enrolled in Medicaid, but they account for 15% and 29% of behavioral health expenditures. So we have to look, this gives us a really good picture of where are we spending our money. And one of them is on behavioral health services. So foster care, behavioral health services and foster care is given the most amount or allocated the most amount of expenditures, but disparities aren't improving. We're seeing higher rates of psychotropic medication administration, difficulties adhering to appointments, difficulty making appointments, and overall increased behaviors. And one of the ways that they track that is through emergency department admissions for behavioral health concerns for kiddos in foster care. So this is what really got my interest in this topic in my master's program, because where are we putting the money? Because we're putting all this money into a pot, but we're not getting what we need out of it. And I do want to highlight that this data is from 2015. However, again, one of COVID, it's not published yearly, but I think it gives us a good picture. And we can only imagine that more money is being spent in these areas, especially as foster care needs exponentially increased during times of COVID, particularly, and families not being able to care for their child. This is not, or excuse me, I want to note that these problems are not just seen in foster care. This is a chronic problem that we see in vulnerable populations. I'm just focusing on one subpopulation. So now my PhD work begins. I needed to find what is known about care coordination for children in foster care. So my idea of all the things that I had gathered from the disparities that are seen is what can we do to help? And after some research in my master's program and then early in my PhD, was to look at what could a nursing care coordinator do at the foster care agency level. And I wanted to just mention that in Minnesota, most foster care kiddos are placed with an agency rather than with the county. There are still some counties that are managing kiddos, but it has become such a demanding job that the county is just not able to support it. So agencies have really taken on this work, particularly Children Home Lutheran Social Services and Nexus Kindred. Those are the two largest in our state. So a scoping review is essentially a systematic review of what is known about everything in the literature about this topic. It's a large undertaking, but in my case, I didn't get much of anything, which is helpful in the write-up, but very difficult because it is a gap. So I want to first kind of talk about the methods of what a scoping review looks like. Is you should search as many databases as you can. And I searched 6 of them. And you need to come up with very specific search terms, which I utilized a resource librarian at South Dakota State twice, who actually grew up with parents that provided foster care. So she was actually able to give me a little bit more in-depth insights about my search terms than what a typical research librarian would be able to do. A scoping review follows a very specific methodology, and I use the Joanna Briggs Institute, and then a Prisma diagram, which Prismas are very common. It's just a flow chart of how you include or exclude resources, which because of time, I won't cover tonight, but if anybody has questions on how to do one, I have some good info for you. I did list the databases that I used. Sorry, you guys are kind of covering my slides here. The databases that I used in order, because it's important to know that Soc Index is at the bottom, is a sociology-driven database, and I wanted to make sure I included that because I wasn't just looking at care coordination from the nursing perspective in the scoping review. I was looking at what is known in general. And the reason that Soc Index resulted in 0 is because it was the database that I used last, and it just had duplicates of what was seen above. So I don't want you to think that the Soc Index didn't have anything. It's just they were all duplicates. But in searching these 6 databases, actually 8, I miscounted, I apologize. I only came up with 11 total articles that matched my inclusion and exclusion criteria. And then I used EndNote 21. It's just an article kind of compilation that helps me sort articles by database so I can keep them all straight. Because if you complete a scoping review on something that is well researched, you could have to sort through hundreds of articles, which is actually a very common thing to do. I just have nothing because I'm trying to establish a research trajectory in a concept that doesn't exist. So that was a difficulty that I had. So looking at the inclusion and exclusion criteria, this can make or break a scoping review. I wanted to look at qualitative and quantitative studies. However, I did exclude policy statements and dissertations. And the reason for that is policy statements are more so making recommendations. They're saying where we should go without necessarily saying where we've been in a literature search. And then dissertations are not necessarily peer reviewed. And then the dissertations that I had looked at were more so looking at care coordination, or excuse me, disparities for children in foster care outside of or like with acute mental health crises. And I'm trying to look at long-term care management rather than what a single ER experience looks like. Foster care youth were defined from ages 0 to 18 years. Now it is important to note that foster care services have been extended to individuals up to 21 years of age. However, you have to have significant developmental delays in order to be included in that. So I limited it at 18. I also wanted to look at foster youth diagnosed with mental health disorders or with behavioral health concerns. So what came out of this review is a lot of our kiddos in foster care are not actually diagnosed, which is an issue because if you're not diagnosed, you can't get the services. So I've really kind of reframed to look at behavioral health concerns rather than an actually diagnosed disorder. And then I used a pretty wide range of dates from 2008 to 2023. And I did go against the date recommendations, but 2008 is when one of the most seminal works in this area was published by a social worker out in California, who I've actually had some contact with. She sent me some of her articles because California really is leading the initiative for addressing some gaps and disparities, which I'll talk about in my concept analysis. Okay, I don't have time to talk about the Prisma, but essentially what this is doing is it highlights the screening process for how I include or exclude articles in a tabular form, and then it gets me down to the 11 total that I had used. But what's important is what came of this. What came of this search. And out of the 11, only 4 articles were a single descriptive study addressing healthcare team members' perceptions of barriers in healthcare engagement that were somewhat related to foster care. One was a retrospective cohort study, but that again was aimed at healthcare team members. One was a controlled trial, which was looking at ED admissions for kiddos in foster care. 2 were case control studies, looking at social worker foster care interactions. And then there was 1 qualitative study, looking at perceived barriers that social workers have to provide care for the kiddos under their caseload. I did exclude 2 policy briefs and then those 2 open dissertations for the reasons I talked about before. So the purpose of a scoping review is to identify the biggest gap. And in working with my advisor after I completed this project is nobody, at least what is published in the literature, has interviewed foster parents and gotten their perspective of what is their lived experience, what are the disparities that they see. Most of the results that I'd gotten from what perceived barriers are coming more so from organizational perspectives, actually they're 100% organizational perspectives, nothing from the family level. So this is really geared, what is my dissertation going to look like? Because we know as researchers that you can't just use numbers to affect policy change, which is the end goal at the end of this. So my dissertation topic was born, is looking at the lived experiences of foster parents caring for a child with a behavioral health condition. There's also no studies looking at the lived experience or qualitative research about the social worker's perspective. A lot of the social worker perspectives are these quantitative results of what should be happening based on the numbers. So I really had to pare back what I thought I was going to do, and really try to address the gaps that exist before I can make arguments for how we need to fix it. Because in order to understand what needs to be fixed, we also need to understand what is working well. And we really have no idea what that looks like. So something I wanted to just highlight in the results is that in going through the 11 articles that I got, is that the results are really segmented by county and state. So what applies in Minnesota does not apply in any other state. So I have to take what is being published in states that are working on this with a grain of salt, because Medicaid is handled at the state level. What I am seeing, though, is California is the leader, but Delaware, Philadelphia, and Ohio have also done some minimal work. I know there's a couple researchers out at the University of Cincinnati that I've met at MNRS a couple times, and even IFNA, that are looking at more so the child welfare system with incarcerations, and addressing those barriers, but not necessarily from foster care specifically. And it doesn't look like much of anything's kind of happening in the Midwest. It's really all tailored to the East and West coasts. And there is some work going on in Canada and Australia. However, their policies, procedures, and even processes for foster care are very different than what we see in the United States. So it'd be very different or very difficult to try to use what they have done to apply it to United States systems model. Also, I made the argument that the disparity seen in different countries could also look very, very different. So there was only one article that had resulted that I had excluded from that. But what was found is that collaboration is needed. That has been an underlying theme that everybody in the articles recommends, but not a to-do of how to do it. So just picking out some of the themes that I had found and what is known about care coordination and foster care is that there's inconsistent interdisciplinary care coordination standards. So 7 articles had discussed the presence of inconsistent standards, but nobody can define who the standard should come from and who should be evaluating them. 4 of the articles highlighted that stakeholders such as the Institute of Medicine, the American Academy of Child and Adolescent Psychiatrists, the American Academy of Pediatrics, and the Child Welfare League of America have provided mission statements for a practice and policy change to improve mental health outcomes for youth in foster care, but there is no roadmap in how to get there. And something else is with these gaps in chronic mental health management is children who enter care are supposed to get a well child screen within 30 days of entrance into foster care. And nationwide, less than 31% are getting this initial screen, which could be a very important time to recognize some of these needs. So they're not even getting to the first state mandated appointment or mental health appointment that is needed. For the second theme, it's important to note that accessible healthcare is not associated with utilization. So 3 articles highlighted the inconsistent healthcare utilizations by this population. And a study of almost 1,000 foster youth in the United States have found that children with mental health needs are getting mental health care less than 30% of the time than what is actually needed. So that kind of highlights a further disparity, what I had talked about in access to those appointments. Minority racial caregiver disparities can also play a role in appointment adherence, as 39% of appointments that have been scheduled by caregivers of children in foster care do not show up to that appointment. So it would be worthwhile to look at what are the accessibility issues. Is it transportation? Is it geography? Is it cost? Because that hasn't happened either. I mean, so the lane here is wide open for research. And the third theme was gaps in chronic mental health management. Some of the commonly perceived causes and gaps in management are found in the complexity of disease. So this may or may not have a rural health component, as it is very difficult to get into a mental health care provider. So primary care providers are doing medication management and attempting behavioral therapy management. And in another study I had done for another project is that many primary care providers do not feel equipped to provide care and long-term management for these vulnerable populations, specifically related to mental health. Foster youth are also not able to advocate for themselves, especially at younger ages, and they're often having to rely on people who have no idea who they are. They've only been in their home for a month or two. So they don't have a long-term trusted caregiver that can help advocate for them. People are making decisions for them without them, which affects adherence from their level as well, especially as a teenager. So then the last theme I had found was a coordinated collaborative care model. Kind of talking about the recommendations that have been set forth by all these policy advocates and agencies, but no clear direction or pathway on how to get there. A collaborative care model, and that is not specific to medical home models, as that terminology was explicitly excluded because they are predominantly physician-led, which has been the trajectory for this research, which is why there's so much of a gap. But I mean, early findings in other disciplines are showing that it can improve medication and appointment adherence, decrease acute hospitalizations, and prevent losing medical information, especially for very transient populations. Some limitations that I had found in doing a scoping review, as there's always limitations, is there's many confounding variables. When foster youth experience multiple relocations, it's hard to keep track of them. They are a vulnerable population, which makes them very difficult to survey, to interview. And then there's that ethical consideration of assent versus consent, which is why one of the reasons that research hasn't been done in this area is you could be locked up in IRB for years, which is why, because I actually wanted to interview foster kids in my study and do a comparative analysis, but people do say a good dissertation is a done one, and I am on a time limit, especially with my job, and I could be locked up into IRB for 2 years, making the argument of could a foster teen be interviewed, and who would be able to provide the consent or assent, especially with the multiple relocations and foster parents. So some other things I had found is that the quantitative articles that did result lacked recommendations to decrease disparities. So the gaps are being defined, but again, we have no roadmap of how to address them. The qualitative articles made interventional recommendations without testing a concept. So it's essentially making a recommendation of, well, let's try it. We don't know if it's going to work or not. But this is what we think should happen with no research base to back it up. One article did quantify the benefits that coordinated care has on healthcare utilization, but that is only one. And again, no study has interviewed foster youth, so it's decisions being made for them without them, is what I had found. So that is a scoping review, is what I found about what is known about care coordination and foster care, which isn't a lot. So the next thing I had found is it has not been defined. What does care coordination look like? Who are its stakeholders? What should it entail? What should it not entail? And who does it affect? So that step goes into a concept analysis. It needs to be defined. So a concept analysis is an analytical research approach that helps us understand a phenomena and generates new knowledge that can be used in future research. Now, there's different concept analyses frameworks. I used Walker and Avant. And it's important to know concept analyses about 20 years ago, is what I'm told, had a lot of respect, and they kind of just went off the wayside because they didn't produce something. It gave us knowledge, but nothing tangible. But what I'm seeing in the couple of conferences I've gone to is in manuscript publishings are giving more respect to concept analyses, especially as research is being done to address these hard questions and these hard gaps, particularly in the social sciences. So I think you will see kind of a rejuvenation of a concept analysis, as long as you can show clear trajectory of what is the so what. What is this concept analysis for, and what could it help lead to in the future? So in the 8 steps, I outlined what these 8 steps are in each of my slides. For time, I just want you to know I eliminated steps 5 and 6 of identifying model cases. They're literally paragraphs of stories that ChatGPT and I made up um, of what constructs should be involved in there or not. And I could spend the whole hour talking about those. But first I had to select a concept. So care coordination in foster care. Then I needed to identify the purpose of the analysis and look at all the uses of the concept. I needed to identify its attributes or definitions, and then look at its antecedents and consequences, which will make more sense when I get to that slide. And then define empirical reference. So how is it being used today? Which it's not. And then create an operationalized definition. So the definition that I have created is the framework that I and other researchers, once I can get this published, use in making an argument of what care coordination in this discipline should look like with the research to back it up, rather than having all these policy briefs from, well-respected organizations saying what should happen without giving the roadmap. So this is just the start of that roadmap. So just a note, something I always do with my students is I put Curious George on slides that requires like further investigation or something that's really, really important. It's just something fun. But care coordination is not new. This was actually proposed in the 1990s. It was advocated for in 2010 under Obama with the Affordable Care Act, but it's been stagnated now in many individual states' Medicare and Medicaid services because it is not included in the current fee-for-service model that gets money reimbursement. This is a value-based model, which is not supported in our current healthcare system. And care coordination has been heavily influenced by policy stakeholders such as the federally qualified health centers or FQHCs and accountable care organizations. And as I mentioned, multiple policy statements have been released advocating for coordinators for children in foster care, such as the American Academy of Child and Adolescent Psychiatrists, the Academy of Pediatrics, and the Child Welfare League of America. But it has taken states over a decade to even get discussions for Medicare and Medicaid to approve managed care delivery systems or care coordination models to move away from this fee for service. And I was actually talking to somebody, I think Christy is here tonight. They had attempted to get one implemented in a Minnesota healthcare system, but it was dropped because they could not prove the actual financial benefits because this would be a longevity study and people want something back for their money, which has been hard to prove. But the other difficulty is that Medicare and Medicaid is so fragmented because each individual state can determine who is eligible, who gets benefits, how much, and foster care is not often at the top of those services. So looking at the concept analysis, the reason I put some systemic failures or barriers that are occurring with social workers in the concept analysis is because the scoping review really focused on the nursing perspective, whereas the concept analysis I had to pull from social work because they're the ones that manage kiddos right now. So systematic failures have caused caseworkers to be overworked. And I didn't realize just how bad until I pulled this paragraph together in my manuscript. Social workers are being asked to address holistic health problems with limited resources, try to maintain contact with multiple individuals and systems while answering to the needs and safety of families, while also trying to satisfy the demands of their staff and administrators. This has led to burnout, turnover, and on this slide, high caseloads. So the Child Welfare League of America published caseload standards for excellence for child welfare workers. And they identified that any one caseworker that works in CPS should have no more than 17 families on their caseload. Now, I want you to note families, not children. So if there's a 5-child family unit, that counts as one family. But 17, okay, is what the current recommended standard is. California, their average caseload worker or caseload averages 100 to 400 families per caseworker. The average in the United States is 69 cases. So any caseworker on average in Minnesota has 69 cases to manage, and 17 is the recommendation. Now the range is 28 to 174 on average, but it's also really important to note that only 39 states responded to the national survey. So it is predicted that these numbers would be skewed even higher, because it can be predicted that the states with the highest caseloads don't have the time to report. So this is a concern. Is a standard has been identified, but now it's not being followed. And then the kiddos and the families are the ones experiencing those ramifications. So moving back into the concept analysis is, what is the purpose? We have a need for a conceptual definition. I want to note that a concept analysis was published a few years ago about care coordination. However, it lacked specificity to a discipline. And although care coordinator roles have been explored in social sciences and psychology for adult populations, the nuances for children in care have not been explored at all. Multiple states have attempted to define this concept and enact changes under CMS guidelines. However, what's been found is each concept that's defined has been outlined differently with contradicting roles and responsibilities. And I make the argument in my manuscript that care coordination needs to be discipline specific because of the nuances of care, which is an identified gap, and why I went with care coordination in foster care specifically rather than just care coordination in general. So the purpose of this concept analysis is to develop a complete definition of what care coordination is with a specifier to a child in the welfare system, because this population has such unique needs that are not being met under the giant umbrella. So the methodology is very similar to what it is for a scoping review. However, I did use that Walker and Avant framework for the steps. I used 6 databases, including Social Index, Psych Info. So I did pull from the social sciences as well. And again, I used that 2008 date to include those seminal works from that author out in California. And then I did restrict it to the United States and peer reviewed. So my inclusion and exclusion criteria were very similar to what I had done in my scoping review. And the process, again, I used a Prisma diagram to outline how I excluded my articles, what ones were duplicates. And after screening for duplicates and abstract screening, I got 12. So I got 11 for my scoping review, and I got 12 for my concept analysis about care coordination. And looking at the similarities in search terms, care coordinator was also used in the search terms to make sure I was getting everything that I could. And again, I utilized the research librarian to ensure that I was getting an adequate picture in my searches. So after conducting my search, the next step is to review all the 12 articles that I could use to define the concept. Where has it been used? How has it been used? And in what context? It's only been formally defined by 2 agencies, by the Agency for Healthcare Research and Quality and the National Quality Forum. And because of time, I'm not going to spend much time on describing what is or isn't here for tonight, but I can send this out, and my speaker notes are in there if anybody would like to take a look at it. So the next step is identifying its attributes. What is included? What is it trying to do? So 4 defining attributes emerged, looking at transitions in care, improving outcomes, managing complexities, and then quality improvement. So care coordination had identified that care coordinators are present during transitions of care from one setting to another. And this is especially true for children in foster care. A coordinator should oversee discharge planning, information transfer, and setting up follow-up appointments. The goal during transition and care is to promote community and social supports and foster resilience during times of uncertainty. And looking at how to improve outcomes, care coordinators can improve outcomes to both clients and families and organizations. And they would provide holistic care, which is culturally responsive um, to the recipients at and when they need it. These cultural preferences can also evolve over time and as people age. So the model must also evolve over time. Also, a care coordinator acts as an advocate to address structural inequalities in healthcare, such as combating racism and stigmas around disease, especially mental health. When consistent oversight is provided from a formal role of care coordinator, care becomes less fragmented and medical records become more complete. They also can provide a bridge or a hotspot for these geographically separated or socially disadvantaged groups to improve outcomes and decrease disparities. One way that this can be accomplished is by using health information exchanges, which is an objective that was identified by the High Tech Act of 2009, or the Health Information Technology for Economic and Clinical Health, is that the majority of medical documentation transfers to electronic to increase usability. For managing complexities, under the value-based payment model, preventative care is emphasized, which is not our current model of healthcare right now. Care coordinators can utilize community and primary resources rather than emergency medical services and emergency departments. Complex medical conditions often require multidisciplinary care from providers and or organizations, and a coordinator role would provide that secure link to decrease the risk of mistranslations and lost records. The care coordinator would also input, track, and send data in real time whenever and wherever the recipient needs it. So it follows them in a very individualized manner. And then the last attribute is care coordinators should improve quality. In 2012, the Centers for Medicare and Medicaid Services initiated a hospital readmissions reduction program, and it was found that care coordination provided the link to decrease hospital readmission rates and costs. When a centralized role in care coordination oversees these medical records, there's a decrease in duplication, there's a decrease in errors, and we even see a reduction in information sharing delays. But due to the complexity of attempting to manage children with highly specialized needs, care coordinators can improve appointment adherence through scheduling assistance and follow-up reminders, especially for foster parents that are caring for more than one kiddo, which is often the case. One study, which is Snyderman out in California, who's kind of the lead or the mother of this research, is foster parents right now are required to schedule, manage, and adhere to these appointments without any assistance, which has led to those high attrition rates. So in identifying the attributes, then we need to identify antecedents. So what needs to come before it for it to be successful? And then what will result from adequate implementation? And because of time, I'll try to synthesize these just a little bit. As I said, I'm trying to put a couple years worth of research into 1 hour. Is we need an established policy. Care coordinator roles are not going to be implemented without CMS reimbursement. We need to implement a values-based service model, and we need to cover at-risk and medically complex children in foster care. It would require a teamwork approach with the caseworker, the guardian, and the primary care provider. And then before and during this whole process, confidentiality would need to be maintained. So the consequences, there's both positive and unintended consequences of implementing a care coordination model. Is a care coordinator would be able to provide timely, culturally responsive, cost-effective, holistic, preventative care. They would be able to adequately support information exchange, and they would be able to further advocate for policy and organizational structure change. Now, anytime you're adding a middleman, because that's essentially what is happening, is there is a risk for duplicated, omitted, or erased medical information. So the platform that is used would need to be conducive to the population. And then when you are working with a person, there's always the chance that information could be misused, whether that be intentional or unintentional. And this comes from the fact of more so from the caregiver or foster provider perspective, because there's a lot of ethical debates on who has access to information and who doesn't, or if rights have been terminated by biological parents, information does get exchanged when it shouldn't be. So those are some of the concerns. So then, you have to define empirical reference, and that is just a fancy term to say how is it being used in practice. Now, that was very, very difficult because it doesn't exist. But something that Schneiderman has identified in her research out in California is in 2024, the first known foster care public health nurse position was advertised and is being explored. So a foster care public health nurse would assist child welfare workers to gather information and help create a health plan, advocate for the needs of the child, and serve as a resource for foster parents, children, group home providers, welfare workers, and probation officers. The public health nurse would coordinate care through an individually devised healthcare information passport. So this has really set the stage for what could be a care coordination role. Could it be a certified position as a foster care public health nurse? And that's what California is working on right now. So then my role comes in, is taking all of this information and making a definition. So based on all the information that I've found, a care coordinator in foster care would have 8 roles. It is 1, it's an indirect care delivery. 2, managed by trained care coordinators. That 3, recruits and cares for at-risk and medically complex clients. To 4, assist in providing timely, cost-effective, appropriate, culturally responsive information exchange. By 5, scheduling appointments and collecting and interpreting information related to medical conditions, medications, and assessments. To 6, for foster children and their caretakers. For 7, across disciplines. To 8, provide timely, holistic, family-centered care to improve the quintuple aim of healthcare. So in all the research that I've been able to do, this is what a full encompassing role or definition of what a care coordinator in foster care should look like. So with all studies come implications. More research needs to be done in this medical home model, because medical home models are a fee-for-service led program, versus nursing care coordinators versus this proposed foster care public health nurse. I apologize, I duplicated here. we need further exploration to establish care coordination gap root causes. Why are these not being established? There's been policy briefs advocating for their use. Other organizations are calling for their use. Is it more than just money that is prohibiting their implementation? It's found that qualitative and mixed method studies will help inform policy reform, which is what is missing from the literature right now. And a lack of data will continue unless nurses ask the hard questions and include vulnerable populations in decisions that are made about them. So I kind of leave you guys with the lane is wide open. It is unclear. It's going to be a windy road with lots of twists and turns. But this is groundbreaking research, really could help get us to this value-based payment model rather than a fee for service. And everybody always asks where my next steps are. Is I am working on both manuscripts for publication. I just the drafting or the editing is just the death of me. I have submitted IRB approval to begin my pilot study for a hermeneutic phenomenological interpretation of what is the lived experience of foster parents. And that'll lead directly into my dissertation topic of looking at the lived experiences of foster parents caring for a child with and I forgot to change this, it's a behavioral health condition instead of just mental health. Especially mental health can still have negative stigmas, so changing it to behavioral health. Because we need to explore what is known because so little is known that we don't really even know what questions to ask. So go back to the population with the population is my approach. After my doctoral dissertation, I do hope to do the same thing, looking at lived experiences of social workers, especially with such high caseloads. What does this look like? Because it's going to be these qualitative studies that are going to help get us to this value-based payment model, and essentially pull at the heartstrings of people that make these decisions, because it's having an impact on people, not just numbers on paper. And then I hope to kind of look at the cross-comparative analysis before I can even apply for grants to try to trial this in a foster care agency. And then I will leave you with this, that the whole purpose of this research, this long winding road is it's easier to build up strong children than it is to repair broken adults. So I fully am standing by, especially right now, that nurses have the power to make change. We just have to take it day by day. And I'm done. I know I went a little over, so I apologize.
No worries. Thank you so much. This was fascinating. There are a couple of comments in the chat. Alex had to leave. She said, great presentation. It was exciting to hear about your research, and she has to put her kids to bed. And is Julia still on? Yeah, Julia, do you want to just, and she said she's having to log out for another meeting, but she said, thank you so much for the hard work. And Julia, are you still there?
Yeah, you can
Okay.
read it. Yeah, I want to join another meeting. This is very extensive and hard work, Rachel. Thank you so much. Being a psych nurse, I've taken care of, many kids from foster homes. Can be very challenging and very overwhelming, even for the parents and for the kids, themselves. So it's an isolated area. Nobody pays attention to it. So thank you so much for, for looking into it. And good night, everyone. Thank you so much.
Yes, thank you.
Yeah, thanks for coming, Julia.
Yeah.
Yes, thanks for speaking up on this topic. It really is relevant and important for us to consider. I appreciate your presentation, Rachel.
Thank you. If anybody wants to join my team in a year, taking volunteers.
Any other questions or comments before we call it a night?
I'd just like to say sometimes what really changes things is just one person making this their life's effort. And I think these children benefit from your work. This is just the beginning, and I'm so excited to see where this is going to go.
It is. And that's what I have to keep telling myself right now is this is just the beginning because I want to get to that end goal, but we gotta do it right. Is what my advisor is saying. So uh
And
so
Jerry wanted to know the best way to contact you. Oh,
got
good.
it.
You took care of it. Good. I think that's
I could,
other than
thank you,
Christy.
Rachel, for your work here. I am also passionate about foster care and care coordination, so this is great. I'm wondering if I can share a foster related thing that people may be interested in along this topic. Foster Advocates is a statewide organization that has done a lot of advocacy and passed several bills related to foster care in Minnesota. And they are coming out with a sort of a research um, uh, product, kind of. It's called it's an effort that they've called Minnesota Promise, and that will be coming out next month. And they have a kickoff thing, which unfortunately I'm unable to attend, but it's going to be on May 8th at Theo. And it's got a lot of voice. It's all entirely done by and for foster youth from various parts of the state. They've been working on this for a few years now. And so I think it really gets to a lot of the like what people are experiencing in the foster world about some of the specific topics you were talking about related to mental health, medications, things like that, access, and kind of where to go next. So if anyone has any questions about that, I can certainly point you in a direction for that. But I think it would be
Promise. Okay.
yeah, it's called the Minnesota Promise. The idea being that a person who goes into foster care in the state is promised that they will be cared for by the state, and is the state living up to that? These guys are also the ones who did that funding for college in Minnesota. I mean, they've done a number of things. They put that ombudsman in office too for Minnesota. So they've done several things in the last 6 years that they've been around. So just
Yeah, I got
just
it pulled
something
up
that
here.
be interested in. Yeah.
Awesome. Okay. Yeah, I'm definitely interested in getting more involved.
Yeah, I did some editing and involvement in the Minnesota Promise, and it looks good. I'm excited to see the final product.
Is there somebody that could
It's really a
specifically
movement. Oh, who you can
contact
contact? Yeah, I
people?
can certainly, like, if you look at the About Us, the Meet
Yep.
Our Team, I would just go
Yep.
right to either um, uh,
There's
Ariana,
Ariana, the
yeah,
director. Okay.
hmm
I don't see contact
and
information.
Elena is good.
Oh,
I can,
got it. I
yeah,
found it.
they're both
Perfect.
really approachable. It's a great organization.
Sweet. Thank you.
Great.
That would help a ton.
All right. Anything else for tonight? I'm just dazzled by your work, Rachel. It's amazing. And thank you so much for presenting.
Yeah, thank you for the opportunity. You guys are kind of my guinea pigs because I'm presenting in Australia at a family conference. So, yeah, I really appreciate your guys's.
Did you know that you have to take us with you now that we've heard the first
Oh,
version?
you have? Well, I'm taking my nephew. So, I mean, if any of you can fit in my suitcases, I suppose. But
You
oh
got
God,
it.
that flight is just I'm just dreading it. But MSU is helping. The Glenn Taylor Foundation is a big advocate or funder for family nursing research, and that's why I've really you know, try to embrace, I mean, the concept of families, because I mean, you can't survive as a child without one. So that is kind of my soapbox.
So,
Australia is going to be great. I mean, you know, they've been a leader in this area for decades.
Right.
Yeah.
So I'm really hoping to meet some people that, and actually this idea, I mean, was really stemmed from my first poster presentation ever in Dublin 2 years ago. So, and that's when I was actually looking at my master's research on medical home models, and then it was feedback from people there that looking at this care coordination. So, I mean, even just looking at tonight, I mean, I know it feels like 2 years, like what have I really accomplished? But um, it is a lot.
a
So
lot.
just I got to get these manuscripts across the finish line, but and then
Meanwhile,
hopefully,
you have students who can do IVs. Thank you all so much
that
for
is
being
true.
here tonight. Our next meeting will be on May, I should have that in my head. It'll be on May 20th, and Martha Turner's going to talk about the revisions to the code for nurses, code of ethics for nurses. So she's always good too. So anyway, have a great evening. Enjoy the last
Thank
of
you. I
your
really
day.
appreciate the opportunity.
Everyone, good evening.
Bye-bye.
All right, bye guys.